I'm excited to talk to everybody about hormone therapy today. I am going to specifically talk a little bit more about menopause and some of the different ways that we can use hormone therapy, but I will dabble just a little bit about how our hormones involve how we think, how we sleep, how we basically interact with the world around us. So obviously this is Carol, and she found her own solution to trying to deal with her menopausal symptoms. So, all right, first, the big thing is, what is menopause? So menopause can be described in many different ways. Menopausal symptoms are the changes that a woman experiences before or after she stops menstruating. That's the technical definition. And then obviously we have surgical menopause. Surgical menopause is the hysterectomy that Dr. Evans was talking about. If they were to take out your ovaries with it, then you are in surgical menopause, meaning you don't have your ovaries, so your body's not producing estrogen and testosterone. I'll talk a little bit more about surgical menopause, more specifically related to hormone therapy. Perimenopause begins several years before menopause and associated with fluctuating hormone levels. And perimenopause, if you read the literature, people will think that perimenopause is from, 40 or maybe 48 or maybe 50. People always ask me, when do I start having perimenopausal symptoms? And the truth is that it's different for everybody. Some people may start having perimenopausal symptoms in their 30s. Other women may not start until they're in their 40s. It really depends on your personal hormone level, okay? And menopause is not having a menstrual cycle for over a year. So if somebody came to me like, I had a menstrual cycle 4 months ago, I would not technically say they're in menopause because it has not been a full year. But if you do not have a menstrual cycle for an entire year, then you are officially in menopause. So if you had a period, if somebody came to me and said, I've had a menstrual cycle in a year and a half, and then they had a menstrual cycle 3 months later, I would be concerned because they should not be menstruating anymore once they've not had a menstrual cycle for a full year. Okay, so menopausal symptoms is a very complex problem. Raise your hand if you've ever personally noticed any hormone fluctuations throughout your life, like whether it's your menstrual, Dr. Evans is raising his hand, whether it's your menstrual cycle, menstrual cycle, or whether it's hot flashes. So menopause we know because there are some pretty definite changes that happen with menopause. We have hot flash changes, so people will have night sweats, they'll feel very hot all of a sudden. Cognitive changes. This is something that people don't talk about as much, but this is something that happens. You have cognitive changes, mood fluctuations, weight gain, fatigue, depression, decreased sexual desire. So these are some of the main issues that we have. People are very aware of hot flashes, but that's kind of someone say, oh, how did you do with menopause? Like, oh, my hot flashes weren't bad. But do you think that person's going to go into, oh, but I gained 60 pounds, or I was really moody, or my fatigue was really bad, or I became very depressed? The reason why we have so many physical and psychological changes with menopause is because, and this is one of my areas that I like to research and find out more information about. So not everybody will agree with me, but there's an estrogen-serotonin connection. And so a lot of the data that I research and look into, because I compare it with menstrual cycles as well, we as women have fluctuating hormone levels, and our hormones are very serotonin-based in very similar to our serotonin receptors in our head. And when we have these serotonin levels that drop, we become depressed. So if someone says, I have a family history of depression, they have a family history of having usually kind of lower serotonin levels. When you have, let's say, somebody comes to me, they're like, my menstrual cycle is like 7 days, but it's not very heavy. I don't have a real problem with my menstrual cycle, but my mood fluctuations are extreme. They'll say, I noticed that probably 3 or 4 days before I start my menstrual cycle that I am so mean and grumpy, that I'll do things that are irrational. My husband will say I'm irrational all the time, but I will say I'm not irrational, and that will last until I'm probably day 4 or 5 of my menstrual cycle. Then I'll do really good for 3 or 4 weeks, and then it will happen again. A lot of this is that estrogen-serotonin connection, where those receptors are dropping and fluctuating to the point where you're noticing the difference both physically and emotionally. So it's a little deep, so it's not something I have time to get into today. But, and there is a scientific fact that does happen. And, having menstrual cycles myself and going through a lot of those things, there would be not a lot of women that would deny that they can tell that they have mood fluctuations with their menstrual cycles. Some women have naturally higher serotonin levels, and they may not notice the mood fluctuation quite as drastically as other women. Okay, so we're going to talk a little bit about hormone therapy. Hormone therapy was established in 1949, global impact really 1960s, oral conjugated estrogens and progesterones, and it was a top-selling medication. So this was something that came on really fast, and people used it, and it was one of the top prescription medications. So what happens? What happened to decrease how often we used hormone replacement therapy? Does anybody know what the Women's Health Initiative was? Does that sound familiar at all? So Women's Health Initiative was a large study that they did that studied hormone therapy. It was launched in 1991, and it stopped in 2002. And the reason why they stopped the study was because it showed increased risk of heart attack and stroke, increased risk for breast cancer, decrease in bone fractures, so that was a positive, and a more marked elevation among the risk of women who began hormone therapy more than 10 years after menopause. The average age of enrollment of the Women's Health Initiative study was 63. Does anybody see where maybe the flaw with the Women's Health Initiative was? How old do you think women typically are when they initiate or start hormone therapy? Okay, maybe 50, 52, 53. If you had surgical menopause, maybe in your 40s. So actually starting, an average age of enrollment was 63, was pretty much on the higher end of where someone would be at when you initially start hormone therapy. So it had some pretty major flaws when they were studying the Women's Health Initiative, or with the Women's Health Initiative, which launched a different study. And the funny thing is, this was when it came out in 2002, it was all over the media. I mean, it was widespread. Everybody heard, and it reduced, I'm trying to remember the statistical data, but I think it reduced the use of hormone therapy by about 50%, like pills, it really drastically reduced. So the Women's Health Initiative did change how and when we treat menopause, and it really did start an alternative hormone replacement therapy revolution. It also increased caution and preventative testing with the use of standard hormone replacement therapy. So with the Women's Health Initiative, it really kind of gave us basically some precautions to watch for, where it said it has an increase for heart attack and stroke, and the chance for breast cancer. It made us think, are we basically providing a benefit for our patients, or are we potentially harming them? And so we had to really start balancing risk versus benefit. Okay, so this next study that came out is the KEEP study, okay? And the KEEP study came out, and it was released in 2012, but it was very poorly published. CBS didn't scream it from the rooftops. Nobody really heard about the KEEP study. And what the KEEP study showed was that basically no adverse effect of hormone therapy when started in early menopausal women. In contrast, there is actually a significant improvement in symptoms of depression, anxiety, and tension. Plus, the cardiac effect of estrogen may actually have been beneficial, and that's something that was largely ignored before because of the average age of the group of patients. It also, I think it was the end of 2013 that another news release came out, and it actually showed that starting and using estrogen therapy if you've had a surgical menopause or surgical removal of your ovaries actually is health beneficial to you and could in fact prevent things like Alzheimer's, osteoporosis, and in fact decrease your chance for having cardiovascular disease, because our bodies are not meant to go through menopause until our 50s, mid 50s, early 50s. And so if you have surgical menopause and are going through having those symptoms too early, it can actually be detrimental to your body. So with all the different data we have from both the Women's Health Initiative and the KEEP study, the real conclusion is that hormone therapy should be used only for treating menopausal symptoms. So we don't just start somebody on estrogen because they have a family history of osteoporosis. We're not going to start you on hormone therapy because you've had osteoporosis in your family. We are going to wait, and only use hormone therapy if you need it. If you're having hot flashes, if you're noticing extreme mood fluctuations, if you're having headaches. So we only use hormones for the express purpose of treating your menopausal symptoms. So the big thing is who should take hormones. The surgical hysterectomy before 50, this is actually one of the indicators that if you don't have a lot of other risk factors, if you've had a surgical menopause before the age of 50, we should be starting you on hormone therapy. It is actually in your best interest to do that unless you have a strong family history of having heart attacks and stroke at a very young age, or very strong family history of cancer. So the big questions that we ask are, family history of cancer. The new one that's really coming out that they're starting to hit more in the media that's really come out in the last 3 or 4 months is Alzheimer's. They've been doing a lot more research on it, and if you have a family history of Alzheimer's, osteoporosis, the new data may be trending towards making sure that you replace or be very aware of your options as far as hormone replacement therapy. It actually may be prevention for things like Alzheimer's, and we know it's preventative for osteoporosis. All right. Okay. So what we do is we treat the symptoms. Okay. So obviously we have hot flashes. Are you tired? Headaches. These are some of the triage that we'll see with people coming in. Are you suffering from any of these problems? Okay. And then we balance the risk versus benefit. If someone comes and they're like, I'm having 3 or 4 hot flashes a day, I'm not going to suggest that we just throw them on estrogen unless they're under the age of 50 and they've had a surgical menopause, okay? I'm going to go through a couple of different steps. I do use a little bit of alternative medicine. We have our bioidenticals that we use. Antidepressants, if someone comes in and they've had breast cancer and they're suffering from really, really bad hot flashes and mood swings and low libido, we will use things like antidepressants because it really can help. And why does it help? It's again because of that serotonin connection with our hormone levels. Okay, I'll also use a lot of lifestyle changes like dressing in layers and caffeine. Okay, so natural hormone replacement. Natural hormone replacement is not bioidentical. This is completely natural, okay? My natural hormone replacement therapies, and I'm going to pass around a couple of things. So when I'm doing natural hormone replacement therapy, I'm doing just complete, let's see which one they have here. All right, okay, when I'm doing natural hormone replacement therapy, I'm talking everything from just vitamins to rimifeminin to B12 and vitamin D. Okay, so there's a lot of things you can use. The plant-based black cohosh, I have rimifeminin that I'm passing around, and this is actually the one that has a standardized process and is a little bit more effective than some of the things you'll find from like Wealth of Health or a natural grocers. There's also wild yam natural progesterone creams that you can use, and you can even have and intake certain foods like phytoestrogens, sesame, flaxseed, red clover tea, and soy. So there's a lot of different things that you can do completely naturally. But the problem with natural is there isn't really any hormone usually in the complete natural. So I'd say if you're really diligent about doing natural, completely natural homeopathic medicine, you need to be diligent about your overall health, exercise, diet, and you're actually really going to have to hit it hard as far as trying to fine-tune your own body, listen to it and see where you may be needing something, and it will work about 30 to 40% of the time. Okay, so Amberen was one of the main natural remedies that was touted really strongly last year and this year. If anybody's heard the commercial, Amberen, it's going to make you lose weight, you're going to feel great, it doesn't have any hormones in it, you know. So Amberen was actually tested on rats, and it has very poor clinical data. So that's one that really is pushed by the media, but we haven't seen any great, really long-term effects on it. The Rimifeminin is the one that I've done the most research on it because it actually has standardized testing on it with actual clinical data to back it up. And Rimifeminin I have found to be very useful. Okay, what are bioidentical hormones? So we talked about natural hormones. Now bioidentical hormones are natural substances found in plants and animals that are compounded to have the same molecular structure as the hormones made by your own body. So we do two different types of bioidentical hormones, okay? Bioidentical hormones come in cream form and they come in pellets. So these are the two types of bioidentical hormones that we use. You can flip to the next screen. Okay, bioidentical hormone cream. It is specifically formulated to fit your hormone deficiency. It balances all your hormones in your body to help stabilize your moods and physical symptoms. And it requires close patient-provider communication. Hormones and creams are hard. They are hard to manage. And a lot of it is because it does require pretty good communication with me. If you're still having hot flashes or you're having symptoms, we may need to increase your dose, recheck your hormones. And so something I have to work with you in making sure we fine tune. It can be very effective, but dose may change over time. I may start you at a higher dose if you are starting your cream really young, and then as you age, I may decrease your creams, you know, just to keep you from having an increased risk. The hard part with the creams is they must be applied twice a day. I like the cream, and it can, with the creams, oh, let me show you, I do have some tubes. All you young girls, just so you guys can see the creams. Can be kind of fun. You just click it. So it's 2 clicks a day. You'll do one in the morning, and then you'll do one at night with the creams. So you can pass it, and it's just lotion them, so you can use it. You can put some lotion on your hands. Okay, so it's just lotion. With the cream, I found that it's most effective if you shower. So if you shower and then apply the cream, it works really good. And then if you rub the cream in, you know, until your skin even turns kind of a pink or red. You know, some people just rub on a cream and then throw on their sweater. So what happens to the cream? It's going to get on the sweater. Because I tell people you got to put on the cream and you got to really rub it in until it's pink, you know, like you really rubbed in the cream, and make sure that you are applying it well. Creams can be very costly. If you have great insurance, it may be around $40 a month. But it also could be up to about $90 a month for your creams, so it can be very expensive. Testosterone pellets. So testosterone pellets, and we do have the brochures if anybody wants to see the testosterone brochures, but these talk more specifically about testosterone pellets, okay? With the testosterone pellets, they are completely bioidentical as well, just like my creams. I use testosterone and estrogen. I do not use progesterone, but it's not available in the pellet. They are inserted into your upper hip area. So they're put in right here. Okay, so we actually do a surgical procedure to put in the pellets. It is a very minor procedure. People, before we put in pellets, will come and they'll be very scared about having their pellets placed, you know, and then we'll put in the pellets and be like, is that it? Am I done? So it's not a very painful procedure. They completely dissolve over time. The big benefit with the testosterone pellets is the cream, sometimes you'll have peaks and troughs because you'll put them on. If you're really active that day, you may use the hormone that you've applied before you put on your next dose. The pellets have a very base therapeutic dose, meaning they will just they will release very steadily over time, okay? So it seems to be a very beneficial way of administering hormones. And the big clear benefit that I see with pellets versus creams is the mental stability. You know, people that really have a hard time with headaches or depression or anxiety, with the pellets, it really seems to keep them quite steady so that they don't have those jagged peaks and troughs. So if someone comes to me, they're like, I'm having hot flashes, but the thing that really gets me is my headaches. You know, my headaches are horrible. I would lean more towards a pellet, you know, versus a cream because of the steady state of administration of the medication. They last for about 3 to 4 months in women, 5 to 6 months in men, and they are subcutaneously placed. Okay, with the benefits of testosterone, you do have a lot more energy, relief from hot flashes, better sleep, pain relief, migraine, headache relief, improved memory and concentration, relief from depression and anxiety, increased muscle mass, increased bone density, decreased soft tissue, fatty tissue, improved physical performance, improved skin tone and hair texture, although pellets do have an association with increased acne and hair growth, and increased libido and sexual desire. With the pellets, there is no increased risk for heart attacks and strokes. So that is one of the perks of the pellets. Along with there is no data suggests that it is contraindicated in cancer. I actually have a couple breast cancer patients that use testosterone therapy. And the new data that's actually come out with pellets is showing that pellets is actually cancer preventative, and it's a really good builder for your natural tissue too. Pellets are very safe and effective for both women and men. I think I have a pellet here if anyone wants to see. So the pellets, this is actually our larger pellet for a man, and this one is kind of, I'd say, this is the 200 milligram pellet, and then we have a 100 milligram pellet. So you can look at it, you can see underneath. Don't open it up because it's an actual pellet, but it's the 100 milligram pellets are about half that size, and it will just be administered a little bit over time. I'm actually starting to draw some testosterone levels not only before we put them, but a month in to just see about how much testosterone we're giving somebody on a daily basis. And the one patient that I had actually had a very similar testosterone level a month into therapy. And so it is really keeping pretty constant levels, all right? The big thing with pellets is gonna be the cost, okay? So, no, you're fine. With the cost of the pellets, pellets cost around $200 for women every 3 to 4 months when we put them in. And for men, they cost around $425. So pellets can be pricey, but people that use pellets love pellets and will pay the price, even though insurance typically doesn't cover it. Okay, so both with creams and pellets, the needed testing is prevention. So my big stand is I don't care if I'm just seeing you to give you a multivitamin or if we're doing hormone therapy, you will have all of your preventative screening done, okay? If you're seeing me for pellets or you're using your creams, I will not refill creams, pellets, or any medications if we do not have your preventative screening up to date. So preventative screening is going to be something just as simple as wellness labs and wellness exam and labs when you're younger, okay, and just making sure you're nice and healthy, to something more complex like mammograms, colonoscopies, okay, when you're older. Before I do creams and pellets, I have to have a hormone evaluation. You know, people come in, they'll just be like, I'm so tired, it's my testosterone. I know it's my testosterone, you don't need to check it, it's gonna cost me money, I just want you to put pellets in. That's not gonna happen, okay? I will check. I wanna check all of your hormones to see where we're at so I know what I need to put you on. It's a very individualized system. I don't use, the same amount for every patient. It will be based on how active you are. It will be based on how low your hormone levels are. It will be based on what type of cancer risks you have. And it will be based on what cancer risks you have, along with what symptoms you're having from the dose I'm giving you. So the big thing with hormones is that it is all about risk versus benefit. If you have a really high chance of having, cancer or problems, testosterone pellets may be a little safer than the cream that has estrogen in it. But the big thing is formulating a care plan that's very specific for the individual. We don't want to give anybody anything that's harmful, and yet we don't want to treat something that potentially could have long-term health consequences in the end, too. With the data that's come out, it is shown that if we don't, actually treat some of our menopausal symptoms with vitamins or with hormones, that we actually could be causing long-term health problems in the future, from osteoporosis to Alzheimer's to even increasing our chance for different types of cancer as well as fractures. And the big thing is, everybody, I want all of my patients to live life to the fullest. The big thing is, it's not how old you're going to live to be, it's how well you're going to live to be, how well you're going to live when you're older. It's one thing to say I'm 80 and I can maybe, watch TV, or I'm 80 and I can still garden and I can go bike riding and I'm healthy and I love my grandchildren. And so that's always my goal, is to get people to have healthy lives as long as possible. All right.